can swing at you. Okay, so that's how you get to the scaphoid. Right there. That's not the only way you're going to get into it. It's actually pretty deep on the dorsal side. Next one is the ulnar styloid. Again, ulna is the fifth finger side. So put your hand down. The little bump that pops up, that's the ulnar styloid. So real simple. There. Ulnar styloid. Right, next one is the brachioradialis muscle. It's an easy way to do it, just like we did in the lower leg. Have her go thumb up. Okay, thumb up, curl it, push up against my hand. Muscle that pops up. Okay, brachioradialis. Right now. So if you pop up, that muscle right there. Olecranon process, it should be one of those high five ones if you get it. Tip of the elbow. Okay, olecranon process is the tip of the elbow. It's where the triceps attaches. Medial and lateral humeral epicondyles, just like we did with the femoral epicondyles in the knee. Again, put your palms out. You should pretty easily find the medial side. It's not going to pop out like it's just going to automatically see it unless somebody's really thin. But if you go in, you should be able to feel that medial side very easily. Okay, and that's what you're going to palpate. The lateral is just going to be just on the opposite side of it. It's going to be deeper. You're going to feel that extensor muscle belly in there. So you actually have to get in pretty deep. And you actually feel a little bit of a soft spot. If you find the muscle belly, just facing that wall there. If you find the muscle belly and you come up, there's going to be a little soft spot just proximal to that. And that's where you get into the epicondyle. Okay. Now a lot of people, especially if they're active, certainly if you lift weights, it's usually a pretty tender spot anyways, even if you don't play tennis. Tennis racket sport individuals, it hurts quite a bit. Okay. Next one, clavicle. Real easy. Find the top of the shoulder, clavicle, collarbone right here in the front. Acromion right off the tip of the shoulder. So you're gonna, if you on the clavicle, when you come out onto the shoulder, you're gonna feel bone, and then as it steps off, you know you're right on the acromion. Okay. On this side, clavicle, walking it off as you feel kind of that edge come off. That edge is the acromion. Okay. Next one is the coracoid. This one's kind of a fun one if you take a guy, because you can pretty much dig in and drop somebody in this. I won't do that to you. Okay. As you find the acromion, as you come in and then work a little bit back to the midline of the body, you're going to come around the coracoid. It's right there. It hurts, doesn't it? Yeah. So, and most people walk up and literally grab that, because most of us are forward rounded. Okay? Those that lift weights are even more so, because most people when they lift weights just do all push exercises and don't do any back exercises, so it reinforces bad posture. I'm not saying it's denigrate, it's just normal society. And so the pec minor below the pec major gets shortened up. And so that's why it's pretty tender on just about everybody. If somebody's usually a pretty active lifter or a thrower specifically, you really see it pretty tender. Okay, so that's why you're sore with that. AC joint, real easy. You find the acromion, just kind of walk back towards, slide your finger back towards the clavicle, and you'll feel a little space or a little divot in between, and that's the AC joint. So you find the acromion, go back towards the clavicle, and you feel that little space in between. Again, it's not real big space. Somebody's maybe had an AC sprain before, but it's not a symmetrical surface. You're going to feel kind of a little lumpiness there. That's because the bones are not real symmetrical in shape. Okay. The next three are kind of like what we did with the knee, the tibial tubercle, fibular head, and the Gerdy's tubercle. Kind of give us 3 points. So the easiest way to find these, because unless somebody's thin, you just can't put your finger on these 3 points: the greater tuberosity, lesser tuberosity, bicephalic root. If you got a bigger deltoid, bigger shoulder, you just can't just put your finger right up and find it. Okay. So an easy way to find this is have them bend their elbow, grab the wrist, and take your other hand and put a finger down kind of in the anterior portion of the humeral head. So if you find the acromion, walk your finger down, not too far, and you're going to hold that position. And now you're going to take their arm and you're going to internally and externally rotate their arm. So my left finger right now is not moving, but I'm moving the humeral head underneath it. So as I externally rotate, I expose the lesser tuberosity right onto my finger. As I internally rotate back, there's the groove, feel that? And now I'm on the greater tuberosity. Okay, you see that? You understand kind of how the movement gives you that palpation point? It's difficult to do that if somebody's a little bit larger in the shoulders. You're going to have a hard time finding that. You're going to just be fishing around in the deltoid. Yeah?
You said externally rotate for the lesser tuberosity?
Correct. Show it on this side. Again, walk it down just a little bit. And sometimes it's easy just to start internally, externally rotating just to kind of give you the feeling of it. But I think once you feel this once, you get kind of the point. So as I externally rotate, there's the lesser tuberosity. Start to internally, there's the groove, and now the greater tuberosity. Okay. So again, this finger is not moving. It stays in the one spot. And you'll definitely feel the groove in about everybody. Last two, spine of the scapula. Go ahead and face the screen. And again, go off the top of the shoulder, just come right back. It's not going to be all the way posterior. It's still going to be a little bit on the superior side, but you'll feel the ridge right here. This is a common one that we make a mistake on. We come up to it, we get it, we start to just blindly walk up to the back of the shoulder, and we start feeling the medial border of the scapula, and we think that's the spine. Okay, start on the top of the shoulder and work posterior, and then you'll feel the spine head. Okay, and if you're on top of the shoulder, you'll feel the belly of the supraspinatus right here, and as you go back posterior, the spine makes itself pretty evident. Okay. Again, working off the top, supraspinatus, coming down, here's the spine right here. Okay, it's not down here, and again, it's not the medial border here. Again, you should be able to feel that in yourself. Okay. Last one is the SC joint. Face the class. Real simple. Right here, sternum, kind of the throat, and there it is right there, either side. And if you saw this on a larger model, it's certainly on a cadaver. You've got a very rounded clavicle going into a flat surface, so it kind of sits like this. And there's a big step off. So it's real easy to feel that on yourself. Okay, it's not a ball and socket. It's not a nice congruent little shaped set of bones. It's very odd shaped. Okay, so again, real simple to find that. Okay. All right, then our special tests. Okay, the first one is a metacarpal compression test. This is just like what we did with the foot. So you can spread your hand out. This is how you check for fractures. So you can do it on the phalanxes or the hand. And again, just like in the foot, all we're doing is just compressing the bones together. So whichever one you think it may be, you know, a distal phalanx, middle, proximal, or a metacarpal, we're just going to go ahead and compress those and check for crepitus or pain. So just like we did in the foot. So it's a great take-home test if you have that perceived boxer's fracture late at night. It's an easy one you can do on your friend. Check, oh yeah, you broke it, good job. Go to the hospital. Okay, so that's an easy way to handle those. The next two, the Phelan's test and Tennell's test, and we didn't go over this injury necessarily in class, but it's kind of what everybody knows, but carpal tunnel. So carpal tunnel, it's definitely something that's still out there quite a bit from being on keyboards and typewriters, although now with more tablets and more touchscreens, it's a little less. At least we think it's going to be a little less, but this is an easy way to test for it. So the first one is called a Phelan's test. All we're going to have Stephanie do is take her hands, drop the wrist down, and we're going to push those together. Just going to push them together. And you'd have somebody hold this for about a minute. If they start getting numbness, burning, or tingling sensations, that's going to be a positive test for carpal tunnel. Shelby, you'd have a hard time doing that. Maybe you'd cast. Okay. But all we're doing is occluding the artery, nerve, vein complex going into the carpal tunnel. So if it's impinged, this position impinges it more. Okay, so that's a Phelan's test. The next carpal tunnel test, have her do this, put her palms out, expose Okay, this space right here, again, anatomically, this is called the thenar eminence. This is the hypothenar eminence. This little space right in between, you're going to take your finger. Tenels is kind of a test for tapping. So we're going to take our fingers and then tap in between. And if we start to initiate some neurosymptoms, numbness, burning, tingling, hot, cold sensations, that would be positive. Okay, you should not have that now. For carpal tunnel, yeah. Again, you have a tight space in there, and if it starts to get inflamed, it starts to impinge upon those structures. So you're just trying to reproduce those symptoms. Okay, so that's Tenels. Snuff box test you saw, so she put her hand out like this, extend it out, the two tendons in between, that little space, and we're pressing on the scaphoid. So snuff box test is for the scaphoid bone. We're checking for a fracture. Okay. Some people really haven't. I've got a pretty good space right there. Just putting your finger right in. Again, it's not comfortable anyways. If you were to fracture that, certainly measured up with the history and stuff on it, it would probably correlate with the fracture. All right, the next one's going to go into the elbow, varus and valgus, just like the knee. Okay, now we're going to do this a little bit different than the knee because we have pronation and supination to deal with. Okay, so you can't really do it the exact same way you did it with the knee. Easy way for it though, if we're going to do varus and valgus. Now again, this is anatomically correct. And so valgus going this way. All I'm going to do now is grab the forearm from here. I'm not bracing the elbow. Now I'm just going to rock it in a valgus motion. Do it at 0 and 30. So that way for valgus, and this way for varus. Okay? That's all we're doing. So real simple. You guys can see it over here. Varus is going to be going out. Valgus is going in. Okay? If you try to do it like you do with the knee, it's okay. You can probably accomplish it, but oftentimes you get false positive tests because you start to supinate the arm. And you think, oh my gosh, just move it a ton. Yeah, it's supposed to, but you're not actually stressing, in this case, the ulnar collateral. Okay? And you'll get a pretty good appreciation of that when you actually grab the forearm and move it that way. Okay? The next couple, the rest of these tests here are going to be up in the shoulder. So sulcus test is a good way to check for ligament instability, so glenohumeral ligament in the shoulder. So just have her arms hanging at the side. They're just going to pull the arms straight down. Okay? If you find the acromion, you'll see this a lot in females, you'll feel a little space open up underneath the acromion. And that will be a positive sulcus test. Now, if somebody's hypermobile, so they have more mobility in their joints, you would see that on both sides. If somebody's got chronic instability, meaning their shoulders got looser and looser, they've had a lot of subluxes to it, you might see that on just one side. Okay? That's a sulcus test. Apprehension, kind of like we'll do with the patella. We're going to put this position, again, what was our common direction for a shoulder dislocation?
Back.
This goes back, or where's the head of the humerus go? Anterior. So it's anterior dislocation. So we're going to reproduce that. So we're going to put the shoulder up, abducted at 90, elbow flexed at 90, okay? And we're just going to externally rotate. When you do this, the head of the humerus rotates anterior. So if you've got an anterior dislocation or maybe chronic subluxation, she would get apprehensive when I did this. Okay? Doesn't feel very good. Especially if somebody was dislocated. They would not like your position at all. Okay? Abducted, arm, elbow bent at 90. So 90, we'll call 90-90 position. Yes?
Is that what you say your body's not supposed to do with the baseball throw and stuff like that? Is that why you said that it messes up your joint?
Well, no, if you're for throwing, this would be more from a dislocation perspective. For throwing, you need to be coming back. I didn't get into some of the details. With throwers, you should have what we call 180 degrees of total range of motion, and that would be external and internal combined. And that's different for everybody. Some people are very tight externally, some are not, so they can go back, but you're still looking for the 180 total. So this would not necessarily be an indicator for if somebody's got a throwing-based type of an injury. This is more for if you had chronic subluxations or partial dislocations or a full dislocation. Okay, you're basically recreating the same motion that it went out on. Okay. So again, apprehension is a positive test. Hey, don't do that. That hurts. Don't like it. Okay. Next two are for AC joints. So piano key and cross arm. Real simple. Piano key, you're going to come right up to the clavicle, and you're just going to push it down like you're pushing a piano key. If it's bouncing like a piano key, that would be a positive test. Okay? Means you've got some excessive play there. You probably would see a correlated AC asymmetry. It'll probably be popped up a little bit more. She has a little play with hers. Okay? You want to compare that to both sides. Just go to clavicle, press it down. Hers presses down a little bit on both sides. She's got kind of a bilateral piano key. Okay. Next one's a cross arm. Real simple. Take the arm, go across. Real easy. Pain at the AC joint. It hurts. And all you're doing is just compressing the clavicle to the scapula. It puts pressure on the AC joint when you do that. Okay, real simple test. All right, the next three are going to be more kind of concussion, head, neck type deals. We haven't talked about those in the lecture yet, but I think they're pretty simple to kind of go through. The first one's a Romberg test. You may have seen this on the side of the highway, okay? Feet together, arms out, head back, close your eyes. It's a balance test, okay? Very simple concussion-based test. Obviously, if they're swaying, losing their balance, that becomes a positive test. Okay, it's a very simple Romberg test. I'll skip down to the Sperling's test first, and then I'll go to the upper motor exam. So Sperling's test is for cervical neck. If there's maybe a disc issue, maybe something stinger-wise, brachial plexus, something along those issues, this is a very quick test, a very easy way to clear somebody. So just have her look forward. I'm going to just compress her neck down. If she has no pain with that, then I'd have her look up, and I would do the same thing. Press down, not real hard. If she has no symptoms with that, I'd go to the next level, which if she was to maybe had a stinger on the right side, I'd have her look right. Compress it down and see if that has any problems. Pain at any of those levels, you pretty much stop, and we probably go further with probably an X-ray. If there's some type of injury pathology you're looking at. Okay, that's called the Sperling's test. So we're just compressing the neck. Yes?
If we get that test on the practical, do you want us to do all?
Yeah, just kind of just go down, look up. It just assume that they're not getting symptoms immediately on all of those. Okay, you're gonna kind of clear all three levels. Okay, for Sperling's. The next one is the upper motor exam. Okay, now you're going to learn the cervical neck. You've got 8 nerve roots, so we're going to test all 8 levels. And these are myotome tests, so we're testing muscle function. There's obviously dermatome tests to see if there's sensation at those levels, but each of those cervical nerve roots, they have a responsibility. So that's what we're going to test on. Okay, we used to call this a cervical dance, so it looks kind of like forward and back, side, shrug, arm out, elbow flexion, elbow extension, fingers. Okay, fast, head. Okay, it looks like a chicken dance. Okay, you can take it to the club this weekend. All right. So, but we actually want to test this as a clinician. So you can do this and do active, but it's probably not going to give you a great test. So you do have to do the resistive aspect of it. So for C1, you push the hand forward, push your head forward into the hand. C2, back. C3 is lateral flexion on both sides. C3, C3. Shrug and hold. Shrug and hold it. C4. C5 is going to be out. Push out. There you go. C6, elbows up. It's really elbows up, wrists extended, but we're just going to make it simple. So elbow flexion. C7, elbow extension. So push down. And you can also add wrist flexion to that as well. And then we get into T1 or C8 T1. use my fingers, tight as you can. That's it, that just tests finger function. Clinically, as you go into probably PT, it gets broken down into a couple more levels, but that's kind of a very quick check. Okay?
We do those again?
Yeah.
Come on, now, you gotta do it one time.
Are you gonna say
I got
just
it.
No, all I want you to test is you just have them run through all of them, okay? So it's gonna be head flexion, head extension, so flexion C1, extension C2, okay? C3 is lateral flexion, so just side to side, okay? C4, shoulder shrug. C5, abduction of the shoulders. C6, elbow flexion, okay, or wrist extension. C7, extension of the elbow and wrist flexion, so opposite. And then 8 and T1 to kind of together, basically hand squeezing. Okay. And again, we break that down in a lot more detail. We have them hold their fingers together and how them splayed out.
What was that, C5?
Abduction. C7, extension. Kind of a quick quiz here.
What did you do for the hand squeezing? You went like that?
It's just squeezing. She would just,
I'm saying, what did you do? Oh, you figured.
yeah, I just take 2 fingers and have her squeeze as tight as she can. And if there's strength deficits on one side or the other, that would be probably an indicator of the level.
So if we get this one, you want us like putting our hand, like doing all
Correct.
what you did? Okay.
Exactly. See, that's what we want you to practice. We're more detailed than probably some of the other special tests, but it's really effective.
That's the
Anytime
one
you've
I'm
got,
gonna
focus
draw
up,
too.
anytime you've ever got a head neck issue, even shoulder issue, this is a great test to check because the brachial plexus is oftentimes indicated in this, even the shoulder issues. We've got a lot of issues over the years. You think, oh, it's a rotator cuff, no big deal. You look at it, and they don't respond well. And then when you go back and check their levels again, there ends up being a deficit, maybe C5 or C4, that you may not have picked up before. And it's something that's coming out of the neck, it's not actually the shoulder. Okay, so it's real effective with that. Okay, so just one more time so you got it. C1 is head flexion, C2 is head extension, C3 is the lateral flexion, both sides, your head-to-head wave. Okay, C4, shoulder shrug. C5, shoulder abduction. C6, elbow flexion, wrist extension. C7, elbow extension, wrist flexion. Okay, and then T1, C8, T1 is finger squeeze. Okay. Good. All right, get with your partners. Practice.
Shout out to the
Practice,
homies.
practice.